Just having some technical problems to begin. Oh, and we are on. Okay. Start. Starting. So, welcome to another individualized talk. Today, it's very special for me, I have to say. You are one of the people that I most admire as a surgeon, someone that
Thank
has
you.
a total dedicated life and it's so focused on this, and you are so focused on getting better and better and improve it each time you do. So, I really gonna love this talk that we are going to have it, and we are going to try to do it as simple as possible. So what I want and what people want is not to hear me, but to hear you, because you know that probably you don't know or you don't have that idea, but you are one of the most influenced maxillofacial surgeons that we have nowadays. So uh, it has been a while
You
that we
make me
know.
blush. You make me blush.
It has
Thank you for
been.
the presentation, Rui.
Okay, but it has been for some time. We worked together for 5 years or something, more or less,
I think
and
it's almost seven, I would say,
almost 7 years.
because
Yeah,
because the first case I've done with you, I have a follow up of almost 6 years and a half. So
yeah,
it's almost
great.
7 years.
So let's start from that. We have start with individualized implants, and maybe you want to share with us what are your approaches, meaning yeah, I know that you play sometimes zygoma implants, sometimes palatal approach, whatever, but and also sometimes individualized implants. Can you share with us what are your thoughts?
Sure. First of all, hello everybody who's watching, and once again, Rui, thank you for this way of presenting me. You actually made me blush because I don't see myself like that. So, uh, first of all, how I come across with this individualized implants theory. I got into. I have a lot of referrals for patients that are severely atrophic, and I've been struggled for some time with a lot of bone augmentation. Uh, I think I went from GBR to bone plates to external um, bone harvesting, extra oval bone harvesting from Calvaria, from iliac crest, and all that. And sometimes it's just so difficult for the patients. And at some point, around 6 or 7 years ago, I started with this with the first case I've done with you, with a lady, very nice lady with a very severe atrophic lower jaw. So this is how it started. Actually, as I said, that is the first case that I would like to show because we have the follow up after almost 7 years. The concept fit, from my point of view, fit the problem like a glove. In specific cases, if you're gonna use the right principle, you get the maximum positive outcome with the less amount of risk. Okay, obviously there is no solution that you can apply without having any kind of risk. So from my point of view, it's a wonderful idea. Obviously it changed since I started with you this kind of implants, let's put it like this, because you developed another type, and I believe it's gonna still get developed further.
Well, we developed together because I didn't tell, but you are clinical advisor. We have the tissue hole that we should call it tissue mircea.
Yeah, yeah, yeah. I believe, by the way, about those tissue holes, I believe they make a little bit of difference. I can see
Indeed.
they making a little bit of difference. And maybe in the future, with the development of technology, maybe uh, actually we will address this in the talk. I believe these kind of implants are a very good solution because they are quite easily put in place. It's not so difficult, and the risks are quite acceptable. They're fast. They offer you an opportunity of rehabilitation the patient fast enough, because when you talk about a 60, 70-year-old patient, those patients want rehabilitation as fast as possible because this is life, they don't have 40, 50 years to wait for that. But there is the problem that I always talked with you, the late exposure of the implant. That is actually, since I've been using personal implants, either for dental reconstruction or for different segments of the facial bone reconstruction, I had only two issues with this product: the late exposure of the product, and in very few cases, and I'm going to talk about it, the fracture of the product. The fracture of the product is something that is easily avoidable by even a harsher protocol. And I think you agree, okay?
Sure.
Everything should be tested digitally first. And I believe that the humans are making the errors, not the machines. So that is something that, let's put it like this: either you as a producer or me as a surgeon, I have to take I will accept that it's our fault when something it's when something breaks. But the late exposure of the implant is something that should be addressed by changing something. What I can think about, either changing the volume of the implant, trying to make it thinner, trying to make it as little as possible, as small as possible, but enough to be resistant for the forces that are stressing the implants, or by changing the quality of the materials in time. I mean, maybe we're going to have materials that are going to be either more resistant in lower volume, or they're going to integrate even better with the tissue, either it's the bone tissue or the soft tissue. But overall, I would say, enough cases that I'm very satisfied with the individualized implants for dental reconstruction. I used to, when I had a very severe atrophic upper jaw, I used to go for quadzigoma, which is not impossible, but it's kind of tricky. You lately, because they get used more and more. You see more complications like implants in the orbit, or fracture of the zygomatic bone, and obviously because the higher angle of attack of the zygomatic implants, you see a fairly great amount of broken zygomatic implants. And only, can you still hear me?
Yes,
Okay.
yes, yes.
Okay. I had a pause in my
Yeah.
earbuds, and only people that didn't see a broken zygomatic implant are able to say that it's not a big problem, because that is a big problem. Actually, we have a case where I had to put a individual implant into a patient that had broken quadzigoma. So it's not quite the best solution in my hand nowadays, because since I'm using individualized implants, I stopped doing quadzigoma, for example. Okay, that is my opinion. As I said, I'm still struggling with soft tissue conditioning around the connector of the implants, because I'd say I have, from my point of view, I have a fairly large rate of late exposure of the implant. It's not a problem that will require removing the removal of the implant, but nevertheless, it's still a problem. When I have a patient with a very good hygiene, it's totally manageable, no problem. But when that is not the case, you have constant inflammation of the mucosa, pain, a little bit of bleeding, and all that. This from this I don't know complication, we started using those holes around the connections, so the tissue is gonna get a chance to get more vascularization from beneath. And it seems that it's a little bit more stable right now, but I don't have all the data, so I totally draw the conclusion that it's definitely working. Okay.
Okay.
I don't know. I
Can you
suppose
share it
I
now?
yes. Let's start with the. For example, this is the first case that I've done. This is the old version of the implantize.
You need to share the screen first.
Yes, I was 1 second. Sorry. Sorry. Select entire screen. Share. Okay. So, can you still hear me?
Perfectly.
Okay. This is the first case that I've done. This is the clinical aspect of the patient. This is a 60, I would say, year-old patient. Now she's probably 67. This was her jaw with the mental foramen on top of the crest. This is very severe atrophic lower jaw. Same here. And as I said, this case was done with the older version of the implantize, where we had one piece. Actually, what I told you then, from some point of view, I like better this version because it has more stability. But on the other hand, require more technical skill to be placed passively all around the bone. And obviously, if you have a problem, something breaks, or you have an inflammation, or something happens on the right, for example, you'll just have to remove the whole deal for the to solve that problem. Okay, these are the images for the implant as it was then. These are the cutting guides, the implant per se, and this is the implant how it fits on the model. I think what I liked from the start was the different surface of the implant, because you have this rough surface in contact with the bone, and you have this machine surface in contact with the mucosa. This was the case. This was the implant in place. Okay, that fit perfectly. This is the post-op, immediate post-op pictures. The restoration, it's upside down. I'm not gonna. Okay, I have the picture with it in place, and I have. This is the most important. This is the image. This is the 6th-year follow-up of this case. So actually, like always, the first case is better than the following. Although the next one you get more experience and everything else. But if we're gonna go back and look, let me see if okay, I have the no. This is the follow-up, 2-year follow-up. Okay, no, this is a different. This is the follow-up, but it's the same situation. I already I have seen that I put a before and after, but this is 2 years, and if you gonna see, I have more fixed and keratinized mucosa. I do not know if I share my cursor also.
Yes, we can
But
see.
I have more fixed and keratinized mucosa after, and in this case, because it was the first, I didn't do anything to the soft tissue. It was just opening and closure, and that was it. Okay. So this is very satisfying. This is the 6.5 follow up. I have a little bit of inflammation here, but everything it's stable in my opinion. So this is one case of individualized implants for oral rehabilitation. Let's put it like this. I have a couple of cases with partial implants. With partial implants. Let me show you. Okay, this is the structure, the shape for the partial implant. It's I like the principle that we always talk about when it's about the lower jaw. We talk about champion's line. When it's about the upper jaw, we talk about the vertical pillars. That old principle, safe principle, proven by time in orthodontic surgery and all that. So we have the fixation of these implants around the zygomatic bone and around the nasal aperture. The guide for sitting, this is the case with very thin bone. We have the positioning of the implant, and after that the suture. In this case, let me see. Let me go back. We can see here. In this case, I've done some phalangeal grafting before the implant because I
Tissue
wanted to
improvement.
improve the.
Yeah.
Yes, I wanted to improve the quality of the tissue, and you can see it. Actually, you can see it here. Okay, this is the OPG post implant, the digital. I don't think I have. Yes, I have the digital design of the implant. Like you do in any cases, this kind of communication is very easy. And nowadays, because you started the software where the clinician can actually rotate and play around with the digital implant is very good. And these are actually recordings from the surgery. So everyone can see how neat and I don't know how good it fits the bone on which it was or for which it was designed. Okay, another video for the connectors also. Yeah, I want to address another topic because I'm seeing these connectors. I wish you would find a way to index the multi-unit abutments onto
Yeah.
connectors. I know we discussed about the mechanical limitation and all that.
Yeah.
Okay, I'm not gonna spend much time in all these details, but this is the follow up, and you can see the soft tissue graft and the fixed mucosa around the connectors. Okay, this was for I would say 75-year old patient. So in my hand, if you ask me, to have fixed teeth in this patient, you either do massive bone reconstruction or you choose this kind of therapy, which is going to be predictable from my point of view and is going to give exactly what a 75-year-old patient would want. You know, the patient are not interested in my surgical skills; they are interested in having the function uh, established. Okay. This case is the case with the broken zygoma, with the broken zygoma. Yes, this is the clinical aspect. I'm going to show you. This is this lady had the quad zygoma actually. They removed the one on the right, and after that put standard implants, and the one on the left we're gonna see it into the bone. This was the scar tissue left. And this is the opening of the case after removing the implants on the right and discovering the implants on the left zygomatic. This was the implant, and you can see from the start that on the right part, the holes for the zygomatic fixation are totally not standard because we had to find some bond between the two zygomatic from between the apex of the two broken zygomatic to put the screws to fix this implant. But as I said, also a nice feature because I'm seeing the pictures. The screws are two-thirds their rough surface, which they also integrate, and only the one superior part, one-third of the superior part, it's machine surface. So this is the implant in place, and you can see on the left the implant follows the broken zygomatic implants, the suturing, the OPG post-op, So we can see the apex of the zygomatic implants. Let me go further, the restoration, and we have the follow-up. I wouldn't know for sure this is 2 years or 3 years post-op. Okay. In this case, I know sure I did something. I think on the right we're gonna see. Yes, on the right I did a connective tissue graft. So you can see it in the end here. Okay. Now this is the design. I don't think we're gonna. Let me see if I can fast forward. I don't think I can fast forward, so we're not gonna waste. Okay, where are you? Let's go to the next case. This is also a very nice case. It's a partial implant where I did first. Now we're gonna start from the beginning. This was the clinical aspect. I had a very thin crest. The patient had the general condition. She had an vascular stroke. She had some cardiac problems. So doing major surgery for me wasn't an option. So I planned the individualized implant. First, we did some conditioning for the soft tissue. We did apicalization and then a FGG graft. This is the design of the implant, but it's also gonna take long if I'm not gonna be able to shorten up. I think it's just a picture. Yes, it's just a picture. Okay. This is the design. You can see the soft tissue. It's way better now. And in this case, I did something that I'm not doing now. In the same surgery, I did a tooth removing and also the implant placement. I don't like that because I cannot control the healing. I can try to do as best as I can, alveolar conservation, but not always has the best outcome. This is the post-op and this is the follow-up. So once again, you can see the nice soft tissue around the connector of the implants. This was the movie with the design. Okay. I'm gonna just go fast forward to the individualized implants. This is another case of upper reconstruction. So this is the digital design of the implant. Also one piece, as you all can see, these are all cases. So the follow-up is present. And when I say it's all cases, because the design of the implant, it's the old design where it was one piece. This is the case, remover of the old implants, guide, positioning of the implant onto the bone of the patient, perfect alignment from my point of view. The stability of the implant, it's always great. There is no question. If you're gonna load the case next day, it's always gonna get dentures the next day. Okay, and this is the follow-up. And I think this is the first case where I had exposure of in this case, I had exposure of the vertical arch of the implant. The implant is still in place and all we have is just inflammation around this area that I tried in other cases to do soft tissue grafting and all that, but didn't work. In my opinion, once you get that kind of exposure, it's I wasn't able
Managing.
to cover. I wasn't. I can manage it because depend on how you use the word. Actually, I consider that I can manage it, but I cannot cover the exposure. Okay.
Sure.
Let me see if I can find another case of. Let's see if we have. Huh. I thought I bought some new design also, but I think this is all cases for when it started actually.
Yeah.
Uh, One second, because I just opened the surgical. So this is another case which was like this. Once again, the design, but I don't see the cursor. I would like to show the design, but not to wait until it's gonna, but I don't have it. So, okay. So this is the thin mandible. Don't be fooled by the picture. This is a 2 millimeters wide bone, something like that. This is the implant in place. Same. The difference, another difference from the old design and the new design are the zygomatic old screws in the late design, and actually the zygomatic implants that we are using for the new models. And I think this is an all on four. I'm not gonna waste my time with that. So this is the X-ray post surgery, and everyone can see how well it fits. Okay, and this is the healing, obviously on the okay, and the clinical aspect. Actually, I have a lot of cases with and I think this is, let's see, this is bimaxillar. Yes. Opa, 1 second. Sorry, Roy. It appears that I was lazy and I got only the old cases, but I can show the cases with the new design also, where the difference is that it's two pieces, which means that it's easier to place because you don't have to expose everything in the whole field. You don't have to open. Oh, you don't have to struggle to put the whole piece into place. But I will tell you, in my hand, not being a problem, I had to say that the idea of having the whole piece one together, it was better for me, because I always knew if I put the implant right or wrong during the surgery, because it's easy when you have this three-dimensional object. If you have a small interference in any part, you're gonna see a huge gap on the opposite part. So it was so easy to diagnose if we put the implant good or bad. Okay, but I understand that it's harder to manage the passive fitting of the implant with the bone. As you can see in this case, also I can, if you are interested, I can zoom in and you can see how well it fits. Okay. And also we have the same idea on the lower jaw, also very thin bone. And I think this is a picture that you liked.
Yeah, I like it very much.
Okay, and this is okay. I believe I
Yeah.
can um,
Anyhow, it's good to have the old cases because
display.
it is something that shows that the concept works.
Okay, sorry, I'm gonna just, because I knew that I had it on the lower part also with the new design of the implant. So this is the last case I'm gonna show about individualized implant for denture reconstruction. This is the case, the opening, and you can see there are two pieces. The concept and the principle are the same. These are the holes that
Mircea holes.
yeah, that we put on top of everything, so we have more vascularization around this area of the implant. And this time we have zygomatic screws. These are, you have to refresh my memory.
2.7
20
to 22 millimeters, and they screw lock. They are screw lock screws.
they screw locks. Okay, so they fix it. Actually, I see in this case I put two on the right and two on the left. Actually, I have a couple of cases where from different stupid reasons. I will call it like this. I only put one, and it was no problem. Okay.
It's a lot of
And
engaging on the zygoma buttress.
yes, yes, yes. And this is, as I said, this is the new design, but it's the same. So what I can say about this idea that I, aside the fact that I like it very much and it's very reliable, what I would like to have in the future, thinner implant, thinner implant, index connectors, and that's it. These
Okay.
are my only desire for this project. Index connectors and somehow thinner design, or maybe a different material that is not gonna is gonna allow for a better
Less
biological
thickness.
integration. Let's put it like this. Okay,
Okay. So,
so
and also you have lots of cases of facial reconstruction that you are going to share with us now.
yes, we can. Yes, we can. I will show you first. This is the case that it's I'm not gonna enter into the details how this patient ended up like this. Unfortunately for the patient, he was 70 years old when I got this CBCT. He had a big portion of the frontal bone missing, secondary to an accident, traffic accident. Obviously, the left orbit it's dislodged. Everything is a mess. This is I've seen the patient after 1.5 year, secondary to the trauma, to the first trauma. So this is not primary surgery. This is the case where we try to cover this area with an individualized implant, and this is how it fit. And obviously, aside this, I had to do some major reconstruction of the left orbit, yes, with some autolog bone harvesting, and this is the reconstruction, and this is the follow up. Okay, but this is not something. You still have other options. Where I found a very good use of the personal implants are in these kind of cases. Let's start with the video this time. Maybe we're gonna watch it. So this is a cancer. It's a cancer patient. We planned. Oh, so 1 second, because I have the diagnosis. It is no, it's an ameloblastoma. No, not cancer patient. It's an ameloblastoma. Okay. And the plan was to resect the whole segment of the mandible and have a primary reconstruction with the personalized implant that will have a connector for the denture later for the fixed denture. I believe this is a problem also in this kind of cases because when I'm going to remove the bone, the tissue in the mouth is going to change. Everything is going to be mobile, and I've seen some difficulties with this connector when they go to the oral mucosa. But nevertheless, I'm going to show the case. So this is the plan, the digital plan. For this case, obviously, we had the guides. I'm going to show you the whole idea. Not so. This is. Let me. Can you see?
Yes, perfectly.
Okay. So these are the cutting guides that are put in place. This is the segmented piece, and this is the implant in place. Obviously, it fits perfectly. The good part is that the condyle it's maintaining the in the position that previous to the surgery. These are the pre-op pictures and the follow-up. The post-op CT scan is this. Let me enlarge it. Sorry. Okay. Okay, I'm very satisfied with the result for this patient. No problem at all. I have to tell you, when I use this kind of implant on the mental area, doesn't work that well. For the vertical or the horizontal part of the mandible, I'm very satisfied because I have a lot of soft tissue to cover this implant with. But when it's in the mental area, I don't think it's a good. Not in my hand, at least, it's not a good indication. A similar case with a similar problem, but this case, no, I think I was lazy. I'm not going to be able to show all this case because I don't want to expose the patient. So it was this case is a secondary reconstruction to a patient that had a benignity on the right mandible. She had the previous mandibular resection with the reconstruction of the fibula flap that failed. Then it was iliac crest that failed, and the patient said I had enough of
Grafts
autologous
or flats.
reconstruction. Yes, enough less, and we use a personalized implant. And actually, remember we talked about this patient. Unfortunately, this personalized implant broke during the surgery.
Yeah, I remember.
You can see we talked about this part, and we had to remove it and replace it actually. But the outcome in the end, it's very good. The outcome, so it's the same concept, and I would say it works very good when it's about the vertical ramus of the mandible and the horizontal ramus. But as I said, I'm not gonna show this case all the way because I have the clinical aspect of the patient here. Um, this is the case with oncology. Yes, I'm gonna show you this case also. That I do not know. Do you hear the music also?
No, no, not the music.
Because this okay. Let me.
No, maybe it's
Okay.
another place.
Okay. So this is a case where we planned the hemiresection of the right mandible with the condyle, and this is the digital planning with the condyle also, and this case worked very well. This is the planning with the design of the implant. I'm gonna go to surgery. The approach was lower lip split. I'm not gonna waste your time with the surgical parts. This is the implant. This is the implant on the model. This is the tumor before resection. This is the after the resection, and obviously the neck was done. This is the piece in place, the piece, and this is the implant. In this case, we cover the implant with the flap from the sternocleidomastoidean muscle. This is the adaptation in the articulation in the temporal fossa, in the glenoid fossa. I'm sorry. I'm a little bit tired. Okay, this is the flap to cover the. No, I don't have the occlusion to cover the implant. But this patient worked very well. Okay. So I think this is the all the cases that
Well,
I had
yeah.
about.
Lately, we
Yes.
have been doing another thing. It's the orthodontic surgery, and we do it in the minimal invasive. And really, I want to know about it, because everyone knows about minimally invasive orthodontic surgery.
So what can I say? If the other two fields that I showed, the individualized implant, let's put it like this, helped me with something that I was quite comfortable managing without in other ways, let's put it like this. When it's about automatic surgery, because this is the situation is not like I had hundred cases done, so the experience you build experience with every case. Uh, Having done digitally and minimally and customized actually for me was mind blowing because I felt that I could get a grasp of the surgery in a shorter amount of time and in a lower number of surgery that I had ever considered. Because now you put some times before the surgery, but during surgery everything goes so easily. Even if, for me, for example, it would be easier to do a cancer case and construct a mandible, for example, than to do an orthodontic case. And this is because of experience and what I feel, what I'm confident with. But with what you've done with orthodontic surgery, that was, I'm telling you, that was a joke actually. I really like it. Let's see where we start. So the whole idea was to put the whole information of the tridimensional movement of the segments of the bone to put it in the pre-bended plate, right? I'm not sharing the screen. 1 second, let me share the screen.
Yeah, at least the position of the maxilla it's almost 100% correct.
The position of the maxilla, I think it's okay. Let's not say it 100%,
But
but it's 99. Yes,
yeah, yeah.
I liked it very much. So let me see this case. What I have on this case. This was, first of all, this is the clinical aspect. As I said, I'm gonna show only the sorry, the CT scans. So we have on class 3. So the planning was done before the surgery. So what I got as a clinician, I got this. Let me start with, yes, this part. Okay. I think I sent you some other pictures with the models and with the product. This is the osteotomy guide that you have
And
on the
drilling.
fixed and sure. Yes, this is the ostomy guide, and for the drilling, yes, for the holes for the pre-bending plate. So from start, I know where to do my osteotomy. I don't have to check anything because I already checked it before the surgery. And so I'm gonna just cut it while I'm listening music. And obviously, because I don't have to see every anatomical part. I get to do a smaller incision. I don't have to do wide incision and everything else. And what I can tell you guys, these guides, they fit and they stay on place so easily. So after you do the osteotomy, you put you drill for the holes of the future plate. Let's do it like this, okay? Is the same on the mandible. The guides, you just, in this case, you just do the osteotomy before the marking, and everything. It's very okay. I And let's see if we have. Okay, this is after we have the down fracture of the maxilla, for example, without having to use any kind of splints, any kind of guides. You just have to make sure that we're gonna put the broken down fracture maxilla with the plates. We're gonna use the holes previously drilled with the guides, and it it fits 99.9% from my point of view. I had to do absolutely nothing. For the mandible, it's the same principle, but I have to tell you, Rui, in this case, I double check with the B plan with the splint that you guys sent for with the final splint, but it worked also. These are the movements, and I think I have a couple of clinical pictures. I have the next case I'm gonna do at the start of August, also digital. So I will try to put more effort in making some better pictures. Let me. Okay, yeah, I think I start from the yes, this is down fracture. I started from the end. I should have started. This is the guiding place. Okay, and this is the actual osteotomy. And if you can see, the incision is from the canine to canine. So when I can tell you from the surgeon point of view, uh, helps a lot when you don't have so much experience. Let's put like this: when you don't have hundreds of cases under your belt, this is very helpful. The the outcome is something like this: before and after, before and after, and we can have the big pictures. What I like about this that you we have only two plates for the maxilla, not four plates. So this is the case. Okay,
Yeah,
I have to say this is the first case with the minimally invasive guided automatic surgery. Stop sharing. Okay, as I said, the next case I'm gonna do in August, but that blew my mind actually.
yeah. In reality, we learn about it talking each other. No, we discuss it a little bit about planning, about how to achieve final results better and better. It's we are just on the beginning, and I think we can achieve amazing results in reality.
Yeah, yeah.
Okay, well, it was, as always, wonderful. You have such nice cases and lots of fears doing this, so it's very good to hear you about outcomings. So these follow-ups they are very old in some cases, and really I have to thank you for your time. I know you are doing such a big effort to talking with us. Nowadays you have so few time to talking with us, but I
I,
really appreciate.
I told you after this I'm gonna be driving for 2 hours and a half. But once again, Ray, thank you very much for all this. Not only the talk, but you helped my profession a lot. And with
Okay,
this occasion, I can thank you openly. Let's play this.
okay,
So thank you for having me.
and thank you for having helping Bonisi to develop their products to be better every time. Okay,
Okay, my
okay,
pleasure. We should talk about, I know, having we talked about the new clinic that I'm opening in my hometown, and we should
yes,
talk about having the courses, having some courses over here in southeast of Europe.
Romania,
Yes, in
yeah, yeah,
Romania.
yeah. Very soon we are going to have lots of training for this for people who lives near Romania and
Be-
Romania.
because I believe this is the future. We just have to adjust it here and there. We just have to tweak some stuff, but I
Details.
definitely think this is the future. Yes. Okay.
Okay, thank you, and
Thank you, guys.
okay, thank you. Bye.
Bye.